Transferring a critical care patient takes teamwork, experience, good communication, and a knowledge of the correct procedure.
The most important component for a safe critical care transfer is the critical care transfer trolley itself. This should be checked by a trained nurse at the beginning of a shift. It should also be checked upon return from a transfer by a trained staff nurse.
Let's take as an example a woman pedestrian who was involved in a road traffic accident. In this case, the patient's played by our own network education lead, Marie Cummins, in her first starring role.
I need more blusher, and my Evian extra chilled.
Let's say the patient has had a CT scan which shows significant intercerebral hemorrhage. She's been sedated and is on a ventilator. She needs to be transferred to a neuroscience unit.
The consultant in charge of the patient will discuss the case with his consultants in critical care, A&E and the neurosurgical centre. The referring and receiving consultant will discuss the risks and benefits of transfer. The decision to transfer the patient is a joint one.
Is my mascara running?
Cut.
Ideally, everyone involved in a critical care transfer should have completed a critical care transfer training course. The critical care transfer should be undertaken by a minimum of 2 escort personnel, one of which should be a medical practitioner with skills in advanced airway management and resuscitation. The escort personnel should be familiar with the transferring equipment and be experienced in patient transfer. The mode of transport should be carefully considered.
Transferring patients in ambulances, if it can go wrong, it will go wrong. One of the most memorable ones I have is a catheter bag after giving a patient mannitol overflowed. We had nowhere else to put empty the urine, so we found a little gap in the step and promptly emptied the catheter bag out the back of the ambulance. I've known of occasions where ambulances have caught fire and had to evacuate onto the side of the road. If it can go wrong, it will go wrong. Take extra of everything that you possibly think of, and some more probably.
The helicopter is a totally different environment to the land ambulance. Modern helicopters, modern air ambulance helicopters have been fitted out with integral oxygen. There is heating in there, and there is less vibration than the older type helicopters that were used. But really it is specialist above and beyond the normal road transfer. There is decisions to be made about the patient's condition to whether that it is appropriate to send them by air, and that needs to be done by somebody who's trained in aeromedical transfer.
The escorting personnel should have experience in acute care, and it is important to identify a team leader. And don't forget to start filling in the transfer form as soon as the decision is made to transfer the patient.
Can I just say about the battery life?
Cut.
It is very important to check the alarm limits on the monitor, the battery life of each piece of equipment, and the amount of oxygen left in each cylinder.
Can I just say about the mobile and the cash?
No.
Remember to take a fully charged mobile phone, contact numbers, and enough cash to get you home.
But I want to say it!
As soon as the decision to transfer is made, begin to complete the transfer form.
Before setting off, it is important to estimate the travelling time, as this has an important impact on equipment. All members of the transfer team should familiarise themselves with the patient's details, including the medical history, details of assessments and relevant investigations. Obtain all relevant transfer documentation, including patient's notes, x-rays and results of investigations. Before transfer takes place, checks need to occur using the ABC approach. If appropriate, the receiving centre should be contacted for specialist advice. Airway assessment should include clinical and radiological assessment of endotracheal tube position. Adequacy of ventilation should be assessed using end-tidal CO2, pulse oximetry and arterial blood gas analysis. Ensure an adequate circulation for the journey, so secure all intravenous access. Bleeding and shock should be managed using fluids and inotropes, etc. The initial call to ambulance control should follow an agreed written down procedure. An aid memoir can be used for this purpose to ensure that relevant details are not left out. Once the patient is ready for transfer, a further call to ambulance control should be made following an agreed written down procedure.
Hello, critical care unit. The ambulance will be on its way to you as soon as possible. Just to confirm, it is a transfer of a head injury patient from your unit to Adam Brooks Hospital.
When we're dispatched onto a critical care transfer, it's essential we know whether they're going to use the critical care trolley, so we can then utilise an ambulance with a tail lift on the back.
632, can you proceed to the Norfolk Norwich Hospital for a critical care transfer using the transfer trolley to Adam Brooks Hospital with a head injury patient? Over.
Some of the checks you do prior to taking on a journey really is to make sure you've got enough fuel to do the job, make sure you've got enough oxygen on board to do the job, make sure you've got enough battery power for those electrical goods you carry, but also planning your route in advance and making sure the back of the cab of the ambulance is actually heated prior to loading the patient.
When arranging a crew, make sure they know the layout of the hospital.
Are we at the right hospital?
If they don't, it can cause delays.
Where are we?
I've got no idea.
I reckon it's that way.
Oh, bloody crap!
A good ambulance crew will ask the clinician how they should make progress on the journey, whether with blue light only, blue light with siren, making normal progress, or proceeding slowly, avoiding bumps.
And how would you like the journey to proceed?
Obviously, in packaging the patient, it is important to follow the correct procedure.
Ready, set, roll. Ready, set, roll.
Then the clinician should re-evaluate the patient using the ABC technique.
Once the patient is ready to leave, one of the team members should lead the way to make sure the route is clear.
You get Dawbridge.
Yeah.
Once the trolley is secured, the patient should be reassessed and made ready for the journey. Oxygen should be connected to the vehicle's supply.
Anything else you want connected before we go?
No, the oxygen's in, that's fine.
The B32745692 via Little Snoring is a very useful shortcut between Norwich and Ipswich. It's often used by tractors and shire horses, but maybe not so good for the patient and crew, so make sure the route is planned carefully.
As well as adopting universal precautions, clinicians must monitor and record all patient vital signs during the journey.
The clinicians should accompany the patient and crew to the receiving unit. The handover should include a verbal and written account of the patient's history, vital signs, therapy and significant clinical events during the transfer. The handover pack should also include X-rays, scans and other investigation results. At the end of the transfer, remember to complete the transfer form and send copies to the relevant people, not forgetting the network office.
Thank you.
Cut.